Hello everybody, this is Lars Hogum, intern doctor in Ålesund, Norway. Back again with another ECG case for you, this time a measurement taken of a COPD patient. And just a quick reminder, for this review we're going to be using the step-by-step chart that you can get at our webpage on the first page at www.ecg.org, and it's on the first page that you'll see if you just scroll down a bit. Alright, so this is our patient for today. It's an somewhat elderly woman, 77 years old, known COPD. She's had very little contact with healthcare providers the last 30 years, which means that there can be potentially a lot of health issues that hasn't been addressed earlier. She is a smoker and overweight. At examination we observe a bilateral pitting edema of the legs. Her blood pressure is 130/90. Coronary examination reveals regular action, clean tones, no extra sounds. Pulmonary examination reveals normal percussion, light crepitations inferiorly, bilaterally, prolonged expiration and wheezing, which is classically found in obstructive pulmonary processes like COPD. We do ECG examination, and please observe that this ECG strip is at 50 mm per second speed, which is the standard speed used in Ålesund Hospital, where I work. So this means that for you guys that are used to the 25 mm per second strips, here one big square like this one, 5 by 5 mm, will along the x-axis be 100 milliseconds. On a 25 mm per second strip along the x-axis here of one big block or square, it's 200 milliseconds. So please observe, this is 100 millisecond, this length. Alright, so the first thing we address, according to our 5-step method of methodically interpreting ECGs, we check for the frequency. And one difference between 50 and 25 mm per second strips is that on a 25 mm per second strip we jump one big block for each number in our row 300, 150, 175, 60, 50. But since this is a 50 mm per second strip, we jump two big squares. Alright, so let's check 300, 150, 100. Alright, let's see. Another one on a thick line is usually helpful. Let's see around here, 300, 150, 100, but it happened a little bit before, so a little bit more than 100, a little bit faster, maybe 110, more or less. So let's see. Right, 110, and it's also wise to just address if it's regular or not, and it looks regular. Alright, so the next step 2 out of 5, is the rhythm and intervals. Let's see, is there a P wave in front of every QRS? It appears so. So this is a sinus rhythm. Alright, let's check the intervals, and remember one big box is here 100 milliseconds. So let's find a P wave. Let's see, around here maybe it starts. Let's see, 100 and 150, so about 150, which is within normal limit. Okay, let's check the QRS complexes. Let's see, it looks like it's within one big square, which means that it's about 100 milliseconds, which is a normal interval. And lastly, let's check the QT interval. Let's see if we can find one a thick line here. Okay, so 100, 200, 300, a little bit more, 340, 330 milliseconds. Okay. Also, when we think about intervals, we also address conduction. And this means that we address the morphology or shape of the QRS complexes. And here we see kind of like a M shape here in these right precordial leads, V1, V2, which indicates that it is a possibly right pulmonary branch block here. Alright, because we see there's no such change on the left side of the heart, and this here you see this noise along here is just a measurement disturbance. Also, we know that this patient has COPD from very old records, and she's a smoker, older now than the old papers we had access to, so her COPD has probably not been getting better since she last had contact with the healthcare system. So let's look for something interesting called P pulmonale, which is peaked P waves in lead 2. Let's see. Okay, so here a little bit sharp P. Oh, hey, here we go. Very sharp P. This is kind of a interesting finding in chronic obstructive pulmonary disease patients, because it indicates right atrial hypertrophy, which can come from increased workload on the right side of the heart with obstructive pulmonary disease. Alright, so we have a P pulmonale, which is agreeable with the known condition. Alright, so the third, let's see, check quickly the answers. Okay, we're on point, normal intervals, and signs of a right bundle branch block. We also see a peaked P wave in lead 2 called the P pulmonale, which can be found in, among other things, COPD patients. It indicates right atrial hypertrophy. Right now, third out of 5 steps. Okay, so with axis we check for 2 thumbs up. Let's see. The QRS in 1 is not exactly positive. It's kind of isoelectric, possibly. Not really. Maybe negative. In AVF we have a positive QRS. So already we can imagine that the axis is moving somewhat towards the right, because let's check AVL. Okay, so it's also negative. So the left-sided vertical leads are negative, meaning the polarization moves towards inferior right part of the heart. Let's see if we can find isoelectric lead. Okay, here in AVR we have an isoelectric lead, and we have positive leads in AVF, so it means the axis is perpendicular to AVR's axis, meaning plus 120 degrees. And to confirm this theory, we can look at 3, which is at plus 120 degrees, and it's strongly positive QRS. So the axis is shifted towards the right at plus 120 degrees. And now the fourth point is to address if there are signs of hypertrophy. Alright, and then we look at the precordial leads, V1 to V6, and we see that the R wave is actually starting, the QRS complex is starting positive with a dominant R wave, and then it becomes not actually particularly dominant as we move towards the left. So this means we have what we call a reverse R wave progression, which can indicate a right ventricular hypertrophy. But the confirmatory testing is done by ultrasound. But it gives us a strong indicator that there is right ventricular hypertrophy, and this agrees with a right axis deviation, which we found at step 3. Alright, so then the last point, ischemia. So we scan all leads for inverted T waves, ST segment shift, and significant Q waves. Okay, so the ST segment looks fine, and the woman did not complain about chest pain in and of itself. But remember always, in elderly women, myocardial infarction can present somewhat atypically. Alright, so it looks like we have possibly inverted T's in 3. Let's see if we have in any other neighboring leads. Let's see, 2, it looks possibly inverted, not very clear. AVF has inverted T's, so this is a sign of inferior ischemia. Alright, so let's quickly summarize. We have a sinus tachycardia of frequency about 110 per minute, normal intervals. However, we observe a biphasic QRS in V1, V2, right-sided precordial leads, which means that we possibly have a right pulmonary branch block. We also observe a right axis deviation at plus 120 degrees. And there's also signs of right ventricular hypertrophy due to the reverse R-wave progression. There's also signs of inferior wall ischemia, but we can see signs of previous infarcts, like significant Q waves, and there's no signs of ongoing infarcts at the present. So we can conclude with this being a possible cor pulmonale because of the known COPD, the pitting edema in the legs, and this peaked P wave that we see in lead 2, which is a associative finding. Now, confirmatory testing would be blood work like BNP and examinations such as echocardiography. Alright, great. Thanks for watching, and see you guys soon.